All right, I'm back. So we're going to be talking about acute non-traumatic weakness. So a 50-year-old female presents to the ER with weakness and slurred speech. Her daughter says that she has not been feeling well lately. She hasn't taken her meds. Her daughter doesn't know what kind of medical problem she has. She hasn't seen her in 3 days. I mean, we'll get histories like that, right? So she's tachycardic. Her heart rate's 115. Her stat is 85% under room air. She's drooling with dry mucous membranes. On her exam, she's oriented to herself, and her speech is too slurred for you to figure out whether she's oriented to anything else. She follows commands intermittently. It's pretty slow. Her cranial nerves appear to be intact. She moves extremities grossly equally, pretty slowly against gravity. You can't really notice any focality, and you can't do a sensory or cerebellar exam. So what do you think's going on? Anyone? Sepsis? That's the answer to everything? That's it? Toxic on something. Okay, so the list of differentials is pretty broad, right? So if you're going to sit there and try to figure this out, this is what I think. It doesn't really matter, right? She's drooling, she's tachycardic, and she's hypoxic. So basically, what you really need to do is look at this in a different way. It's not about what the cause of the weakness is. Let's look at it in a different priority. First of all, the airway and ventilation, which we're pretty good at doing. And the second one is it an emergent problem? Is it something that we need to fix right now, or can it wait? And then try to figure out, is it a central cause or a peripheral cause of weakness? So this is the EMLS protocol, and I'm going to be up here. Where's my pointer? Whoop. All right. So airway, breathing, circulation. We're pretty good at it. We've said that in every single lecture today. So how are you going to figure out who needs to be intubated? When a person comes in with neuromuscular respiratory failure, the muscle weakness can be either up here in the oropharyngeal area, or it can be down here in the respiratory muscles. The diaphragm is the driving force for around 2/3 of our respiratory effort, and then you add the intercostals into that. So that's a pretty big chunk. For oropharyngeal weakness, is the patient having any signs of upper airway obstruction? Are they aspirating? Do they cough when they swallow? Is their cough weak? Are they dysphonic? Are they drowning in their own secretions? And that can be a little easier to figure out than the second category, which is respiratory muscle weakness. For those of us who like numbers, here are the numbers. Get an ABG. If the PaO2 is low, the PaCO2 is high, then failure, right? You can do bedside pulmonary function tests. So you can do vital capacity, which is basically the maximum volume of air that you can exhale in one breath. The normal is around like 40 to 70 cc's per kilo. Maximum inspiratory pressure, so you just ask the patient to inhale real deep and see how much pressure that generates. Expiratory pressure is the exact opposite. Negative inspiratory force is pretty similar to inspiratory pressure as well. The problem with this is that if you wait for the ABG to become abnormal, that's too late. The problem with bedside pulmonary function tests is they're very effort-related, they're coaching-related, and they require that the patient's able to close their mouth around the tube, so they're having any oral weakness, then that's going to alter the results. And last but not least is availability. For NIF, all right. So for NIF, you can actually do that on a vent if your respiratory therapist can figure out how to do that. So that's a little more available than the rest of them. So what are you going to do? Before that, so since we already mentioned that, if you're already getting pulmonary function tests, these are the numbers you're looking for. If you have any of these numbers, then your patient needs to be intubated. If the vital capacity is less than 20 cc's per kilo, if the maximum inspiratory pressure is more than -30, or the expiratory pressure is less than 40, or the NIF is less than 20, this patient needs to be intubated. Now, what if you're not going to be doing that, or you're not going to wait for this to actually happen? Just watch the patient breathe. If their breathing is rapid and shallow, that's one tip. If their breathing is actually starting to slow down because they're getting so tired, if they're using their accessory muscles or having abdominal breathing. Now, the thing is that with respiratory muscle weakness, with rapid breathing, the tidal volume does not increase.